This video presents the new science of dynamic diagnostic relationism. This science relates to the generation and study of motion images of adverse clinical conditions from complex clinical data sets. It involves the conversion of numbers derived from medical lab and vitals and other information into motion images which are easy for everyone to understand. The reason we have to move to dynamic diagnostic relationalism from threshold science is that there are no thresholds of unexpected hospital death. There are only the dynamic relational patterns of unexpected hospital death, and we will show some of these in this discussion. Now, using this new science and technology, we're actually able to detect specific adverse drug reactions and adverse clinical conditions, but perhaps more importantly, we can generate visualizations that everyone can understand that shows the actual evolution of the condition so that they can be preempted. One of the visualizations that Storm Tracker provides is the radar weather map. Think of this as a conversion of the body to geographic space. For instance, states in the United States which relate to physiologic systems of the body. For instance, this is the inflammatory region, the hemostatic region, or the clotting system, the acid-base system, the renal system, and the respiratory system. Now, when an adverse event evolves, and this may be an adverse drug reaction which is causing changes, or an actual clinical condition, then storm cells will begin to develop within these regions. For instance, in sepsis, inflammation storm cells will begin to develop here. If it's an adverse drug reaction to opioids, changes will generally develop in the respiratory system with the storm clouds developing there. If, on the other hand, it's an adverse drug reaction to an anticoagulant, this will develop in the hemostatic region and may also develop in the hematologic region as the patient develops blood loss and anemia. So, Storm Tracker provides the ability for everyone to connect through the metaphor and be able to talk about the case without looking at numbers that they don't understand. This gives the ability for people with different levels of education, different cultures, patients, families, all to be able to communicate and see what's actually happening. So let's look at this case. This is a patient who presented with Ebola virus on day 10 to a hospital containment unit in Germany. So here you see the patient on day 10. The patient has a fever, evidence of mild sepsis, some significant diarrhea. All of this is quite obvious right away without, again, looking at numbers that the family will not understand. Now, as we start to move on the timeline, we're now at day 11, we're now at day 12, we're now at day 14. You see how the patient is getting worse. It's very clear that the patient has serious problems. This evolution is obvious. It is occurring within the system. These look like tiny hurricanes, for instance, within the hemostatic region, the inflammatory region. The patient has evidence of sepsis worsening. All of this is quite obvious. No one has to be looking at numbers they don't understand. So you can sit and talk to the family, show them exactly what's happening, and everyone can begin to connect to the fact that this condition is evolving. Now, as we follow this patient out further, we see the patient then progressively improves. And over time, the patient finally recovers and is only left with Ebola virus in the urine out toward the end. So this new type of technology provides an ability for everyone to begin to communicate, to come together. But we're going to show that actually Storm Tracker does a lot more than that. Storm Tracker actually is a new technology that no longer simply looks at thresholds, but actually is looking at dynamic relational patterns to help identify and track the progression of disease. The goal is to detect, identify, quantify, track, treat, and then detect recovery. Before I go forward and discuss the science of Patient Storm Tracker and its functionality, it's important to consider the present science which is being applied to patient monitors, clinical trials, and bedside detection of adverse conditions. This science is threshold science, which was introduced in the late 20th century. Most medical personnel who've trained in the 21st century may not even realize they are using threshold science. Threshold science is a type of reductionist science which tries to control the complexity by defining a set of thresholds and then applying those thresholds as if it were the actual condition. So threshold science holds that the sensitivity and specificity of a dynamic, complex, rapidly evolving condition can be defined by selecting optimal static thresholds. This is an example of the application of threshold science. These thresholds were defined after the beginning of the establishment of threshold science to determine the presence of sepsis. These thresholds are then applied in clinical trials as gold standards. Weaknesses of threshold science we have learned to our sorrow over the past decade have been alarm fatigue, false sense of security, non-reproducible clinical trials, in particular due to oversimplified input for statistical analysis, and inability to detect transitions. For instance, the transition and development of superinfection, the development of recovery, the development of worsening are all difficult to define utilizing thresholds. This is an example of the application of thresholds to the white blood cell count. Recall that the previous white blood cell count was set to a value of greater than 12,000 and less than 4,000. So you see the normal white blood cell count range. But the actual pattern, or the phenotypic pattern of white blood cell count, which often occurs in sepsis, includes a rise in white blood cell count which may not reach the threshold in the early part of the sepsis, and then may peak and then return back down to produce a threshold error zone in the late part of sepsis. Now this may be offset by trying to use a band percentage, but it's going to be very difficult to select a specific cutoff for the band percentage which is going to protect the patient. So this is an example of how oversimplified threshold science really is. And it produces error zones, and this is simply with one signal. When you try to bring all the other signals together, threshold science simply fails. So the new approach is dynamic diagnostic relationalism. The view of this science is that threshold science is incomplete, and that the relation emotion images of all the available relevant data in time and relational space define the patterns or the vectors of the sensitivity and specificity over time. This will become very clear as we go forward presenting Patient Storm Tracker, which applies the science of diagnostic relationalism. So in contrast with threshold science, dynamic diagnostic relational calls for tracking all available relevant relational patterns over time. And this is what we are going to show. What I'm going to present today is complex thinking. It's difficult stuff. It's much easier to learn the thresholds, but these really haven't worked. So first we have to recognize that there are no thresholds of unexpected hospital death. There are only the dynamic relational patterns of unexpected hospital death. In particular, those patterns are like motion images. If we're going to do sensitivity and specificity, we have to do it on the patterns. We can't do it on some data fragment or part of the pattern. This is the reason that threshold science today can't work. The studies are not reproducible. We look broadly at all the clinical trials are simply not reproducible once the complexity reaches a certain level. This is also why it's worth the time to understand this new technology, which presents the dynamic relational patterns of pathophysiologic processes and shows how we can connect those patterns to actual clinical conditions and how we can use those patterns to define statistics and move forward at the next frontier of clinical monitoring and patient management, and in the next frontier of continuous quality improvement. So how do we detect and quantify dynamic relational patterns and generate motion images of clinical failure? This is performed by the Patient Safety Processor, which is a processing core of Patient Storm Tracker. The Patient Safety Processor takes data in from the electronic medical records database. It may also take in monitoring data and other source data, and then generates a gigantic time series matrix, which may be hundreds of time series wide. Now each time series often may have an event, which we call a perturbation. For instance, this may be a fall in platelets, followed by a rise in platelets. There may be a change in a drug dose. There may be a slow drifting of values, such as a slow fall in hemoglobin. Each of these we call perturbations, and the perturbations are converted into objects. And now we have an objectified time series matrix of all these perturbations. Now, combinations of perturbations, a whole grouping of perturbations, such as, for instance, a fall in platelet count associated with a rise in white count, and a rise in the band count, and a fall in the bicarbonate associated with a rise in the lactate level. All of this we would call a distortion. A distortion is a combination or a grouping or a relational pattern, an evolution of perturbations which are indicative of a particular condition. And then we generate color motion images of these distortions, and we project those out over time. Here we see the conversion by Storm Checker of massive amounts of data sets on the left panel into a time series matrix on the right panel. We see, for example, the CBC, the basic metabolic profile, the comprehensive metabolic profile, different ungrouped laboratory tests, the amount of diarrhea, the intake, the output, the fluid balance. All of these data points are generally recorded in the electronic medical records and then are converted into a gigantic time series matrix. The matrix is divided by inflammatory system, hemostatic system, acid-base system, and all of the different physiologic systems. Now, at first glance, one gets an idea pretty quickly of the complexity of the data in managing a patient. Physicians really have trouble managing all these data and understanding all these relationships. Any trend may be important. Any group of trends may be important. Now, we've exposed this level of complexity to try to show the actual matrix that's underneath the management of each case. Physicians and nurses are used to looking at components of these. For instance, they may look at the CBC, or they may look at the metabolic profile. They may try to look at these in comparison with each other. They may combine time series and, for instance, an EMR to try to look at relationships. But the extent and complexity is simply overwhelming. So what the fundamental solution has been is to try to select basic thresholds to basically reduce this down to certain thresholds and make decisions based on those thresholds. For instance, on day 13, you see the patient had a threshold of white blood cell count. For instance, if we click on the white blood cell count, we see the patient cross the threshold of white blood cell count here, and then, for instance, the antibiotics are started here. So it may be that they were using that specific threshold or certain combinations of thresholds to make their decisions. So this actually works to some degree, but it's an incomplete understanding of the actual condition. There's much greater complexity there that has to be understood. And the solution is not to reduce the data down to certain specific thresholds, or rather identify and compare the dynamic relational patterns that are evolving, and then do sensitivity and specificity analysis and make decisions based on the dynamic relational patterns rather than try to do that based on thresholds. So rather than trying to reduce this complex set of data down to thresholds, we convert it into a matrix, a massive time series matrix, but of course this is also very difficult to interpret. So one has to then detect the patterns along the matrix, detect the relational patterns along the matrix, and then we generate images of the matrix that reflect the actual patterns and relational patterns that exist within the matrix. So this is actually what Storm Checker does. Storm Checker takes the information that's in this massive time series matrix and converts it into motion images. So for instance, this historical weather map, which is actually a projection of the number of and magnitude and types of perturbations and distortions that evolve over time, is projected out from day 11 to day 27, and then at individual times these are shown in the map above. And we will discuss how this is generated. This is the radar weather map, which is divided into systems. You note, for instance, the inflammatory system, the hemostatic system, GI system, Now, if we click on the GI system, we see the patterns that relate to the GI system. For instance, here we have a patient which had severe diarrhea up to over 8 liters in one day, and we see that the patient also had significant vomiting. So we can click on any of these systems and see the perturbations that relate specifically to that system. The historical weather map provides the ability to look globally at the state of the patient. For instance, we see here that this patient came in and was transferred to the hospital in Germany already quite sick. And then actually over time, up to or in the range of day 15, actually was getting worse. And then over that subsequent time out to day 27, progressively improved. So the historical weather map provides an ability to sort of get a general idea of how the patient is doing. One can make a quick look and see the extent of perturbations that are present. Here is a view of 62 patients wherein their global historic weather map is presented in a panel. This, for instance, could be provided for the entire hospital or for a floor and monitored by a CQI department or by a command center. This provides the ability to see the progression of the case, and then the physician or nurse can go inside an individual case and look at this case. For instance, this case was a prolonged hospitalization lasting day 13. Although the patient improved very early in the case, the condition was quite prolonged. So this would provide the opportunity to examine this case during the manifestation of this prolonged hospitalization to determine whether additional intervention is required or earlier discharge. But we can also look at the historical weather map based on clinical space. And we can see in this particular case that the dominant distortions of the matrix or the dominant magnitude of the perturbations actually exist in this particular case in the inflammatory region. So you see the patient had mild distortions producing inflammation here, but these progress severely. So if I enlarge this so we can see this a little better, we look at how we can actually relate the distortions of one system to a distortion in another system. Now let's look at how a storm tracker can be used to determine the timing of treatment. For instance, it's important to know the timing of antibiotic therapy as well as the timing of IV fluids. So if we look specifically at one section of the storm tracker, looking at the provision of IV fluids, we see that here on day 13, the patient received ceftriaxone as initial antibiotic after transfer to Germany. And we see that the patient had already received massive volume of fluids. For instance, here 13 liters, here 11 liters. In association with this massive volume of fluid, we see a fall in creatinine and a fall in BUN, suggesting the patient was dehydrated and that this fluid was being replaced. So we can look specifically to try to understand that by looking at the GI system. And we see that the patient had massive diarrhea, here over 8 liters, and massive vomiting, which explains why the patient was receiving those levels of fluid. But it's important to note that the timing of the fluid provision, the timing of the antibiotics, can all be related specifically to the timing of the diagnosis and to the actual timing of the patterns which evolved. But perhaps more importantly, it also is possible to look and see whether these particular antibiotics were effective. And this is something we're going to show in the next discussion.
Now, one of the purposes of the weather map is to allow the interpretation of the data to become much easier. It provides a transeducational and transcultural visualization so that everyone can communicate together. The physician can point to the weather map and show the family why certain aspects of the patient are becoming more severe and they may need to take certain steps to try to prevent this. Also, the family may be concerned about particular evolution and can talk to the physician and understand why this is or is not being treated or addressed. Now, we note particularly in this particular patient who presented on day 10 with Ebola virus infection that the patient became much more severe later. For instance, at this level, the patient has a relatively mild infection, and here has profound infection, which suggests a severe bacterial superimposition. Now, the weather map demonstrates this dramatically, and when one looks at the historical weather map in particular, there's a very prolonged period where the patient is actually getting worse. No one has to ask why did this patient become so severe under close care? Why was the patient becoming so much worse? Fortunately, Storm Tracker, we can take a look at the treatment and try to see whether treatment might have played a role. Now, if we look first of all in this patient, we notice that early in the care of this patient, the patient received ceftazidime. This actually was before the patient arrived to the location in Germany. Then when the patient begins to develop a severe infection, which suggests the possibility of a bacterial superinfection, the patient was treated with ceftriaxone. We can see the points at which the patient was treated with ceftriaxone here and here. But considering the fact that the patient had ceftazidime earlier, and then is subsequently treated empirically with ceftriaxone, one would not expect the patient to respond favorably. And this, in fact, is the case. We see that after ceftriaxone, the patient continues to worsen. Fortunately, the patient had an adjustment in therapy responsive to blood cultures, which were obtained on the 14th. And at that time, the patient was identified as having a resistant organism, and his treatment was switched to meropenem. Now we see the treatment with meropenem over this timeline and the patient progressively improving. So it's clear from looking at Storm Tracker that it's very easy to detect when therapy may not have been optimal. They obtained cultures and intervened quickly with the correct antibiotic, which was meropenem, and salvaged the patient. This is commonly not the case. Often there's a further delay because the physicians have anchored on the original antibiotic and think they are treating the patient, and therefore a very prolonged, severe, and often fatal and very expensive infection may ensue. Now, it's important to recognize that Storm Tracker provides a window into identifying when antibiotics need to be reconsidered. Now let's look a little closer at how Storm Tracker helps us understand the dynamic patterns which are evolving. Remember, we mentioned that the patient was treated with ceftriaxone, and you can see the timeline. I have the cursor over this space on the historical weather map. On day 13 at 5:42. This is also evident up here. If I look at the matrix, it's also at that same point. Now, if we move over and look at the historical weather map, we move along the timeline of the historical weather map, we see again by day 15 at 1700 hours, the patient still has evidence of sepsis worsening in quite severe state. Now, one would question whether that's sufficient time for the patient to actually be recovering, but it's important that we can identify specifically the presence of deterioration within that window. If I move here and I move the timeline to around the point where we were concerned about sepsis worsening, right in this area, and you see the patient has sepsis worsening at this point. Now I can click on this. This is sepsis worsening actually comprises a distortion of the matrix. And you can see right here that distortion of the matrix is identified right at this timeline. So, for instance, the rise in white blood cell count, the high fever, the rise in absolute neutrophil count, rise in anti-GAP, the fall in bicarb, and the rise in lactic acid, and the rise in heart rate. All of these combine to produce the image of sepsis worsening, which we see here. Because we are using a specific term worsening, or using a specific term that refers to the fact that we have a dynamic distortion,
The perturbations, which are the components of the matrix distortion over to the left, actually are vectors or trends that reflect the evolution of the condition. Now, some might be thinking that it would be nice if Storm Tracker automatically detected delays, for instance, detected the delay in diagnosis, detected the delay in treatment, and warned of those kinds of evolutions. And this is certainly the function of Storm Tracker. We are simply showing here how a physician or nurse can go back into the system and identify the actual reasons that the Storm Tracker made these decisions. Remember, the concept is the concept of computational transparency. In other words, as the machines get smarter, we want the physicians and nurses to become progressively more intelligent about how the machines are making these decisions. We want to move away from the concept of black box decision making. This is not to say that machine learning is not beneficial. In fact, Storm Tracker has advanced machine learning capabilities. But the point is that results cannot emerge from a black box. Physicians and nurses must have the ability to go inside and see why each decision was made, exactly which perturbations were identified to identify a specific pattern. The point is, as the machines get smarter, we want the nurses and physicians to learn together with the machine to develop improved capabilities. So in developing the functional characteristics of patient Storm Tracker, we wanted to address what we consider the essential 4 T's of healthcare cognitive support. The first is that any technology needs to be transeducational, because there isn't just one person evaluating the patient. So all the parties need to have the ability to understand the output. So the physician, the nurse, the patient, the family, the administrator, the researcher can all choose motion visualizations of clinical failure which suits their educational level and preference. The second is it needs to be transcultural. The diversity present in these environments is quite significant. And therefore, it's pivotal that healthcare workers and patients across a wide range of countries and cultures are provided with a unifying transcultural metaphoric output, which they can all understand. And finally, it needs to be transdisciplinary. The researchers, the healthcare workers from each discipline and specialty must be able to engage in a collective effort with unified scientific representations of clinical conditions. And finally, it needs to be computationally transparent. So the 4th T is transparency. Healthcare workers should not have to use the outputs emerging from a black box. All processing should be open for clinical interpretation, study, and immediate review in a format easy to understand for oversight by the clinician at the bedside. It is important to emphasize the last T, to consider its particular relevance in the field of medicine. When applying statistics to large populations to determine sensitivity and specificity, we have learned from personalized medicine that unlike the financial sector, where we can offset losses with gains, the healthcare environment must have a way where the physician can interact and not become dependent upon the black box, and can protect the patient against the dangers of statistical insignificance. So it's important as we go forward that we keep a focus on the fact that all 4 T's are pivotal. So the reason that transeducational and transcultural outputs are pivotal is that giving patients their lab numbers, for example, giving a patient who arrives in the ER their lab values, or giving that to the family, does not empower them. Empowerment is derived from understanding. And families need to be empowered. They often know the patient the best and are intimately committed to a patient's protection, often recognizing subtle warning signs. In contrast, even a good physician who does not know the patient may anchor on the view that the patient is not in trouble. Physicians often discount threshold breaches because thresholds are commonly breached in the absence of severe conditions. This is a form of alarm fatigue. So if the threshold is only breached by a small amount, it's easy to simply discount that if the patient looks fairly healthy. So numbers don't empower because they're too complex. Empowerment comes from providing images, metaphors that the family can understand. Here, for example, is a set of numbers that were published in the New York Times. These represent the laboratory values of a 12-year-old boy who presented to the emergency room, and the physician thought the patient had the flu. Now, even if the physician had provided these numbers to the family might not understand them. The physician might talk to them about the lab values, but the family's not empowered to really see what's going on. And these lab values are complex. Even physicians may make a mistake considering these lab values. Consider, for example, that the white count was only 14.7, which is almost normal. On the other hand, if the patient has more advanced disease, that same white count, the exact same number, can represent high danger. Only by considering the white count in relationship to another value, which is the band percentage, can it be recognized that this patient is in terrible trouble. Also, the platelet count of 117 fails to reach the standard threshold of 100, so a physician might discount that platelet count. So it's very important that we have to provide an output to the families so that the physician and the family can sit down together with an output, both understand, and then communicate about the patient so that the decision can be made with full empowerment of all the parties that are present. Now, if we convert those numbers into storms identified on the radar weather map, this is what the boy's condition actually looks like. So, as you can see, if the family was provided with this information, they would be able to interact with the physician and talk about the fact that there are these storms present and together decide what to do about it. But as long as the laboratory values simply represent complex numbers on the page, the family generally does not even bother to ask for the laboratory values. They're simply assuming that the physician has taken the steps to evaluate the laboratory values to assure that everything is okay. In summary, the goals of dynamic diagnostic relationalism are to detect the dynamic relational patterns, to identify the dynamic relational patterns, and to quantify the dynamic relational patterns, and then to track the patterns and identify pattern changes, and detect or trigger treatment. And then finally, to detect and track pattern transitions, recovery, worsening, or adverse pattern events in association with treatment. But perhaps more importantly, our goal is to make death by unrecognized storm a very rare hospital event.